All right, can everyone hear me? Oh, this is perfect. Okay. All right, hi guys. Welcome to Dry in the Desert, Wu University, Las Vegas edition. We're so excited to have you here. I'm going to be doing the presentation for Zenlens to kick off the day, which should be really exciting day about dry eyes and how to fix them and all sorts of cool things.
Yeah, and everyone that doesn't know Dr. Morrison, she has an amazing scleral lens practice in Scottsdale, Arizona. We ended up becoming really good friends around the same time because we were opening up the exact same type of practice at the same time in two locations. And we thought that Dr. Morrison would be perfect to bring to Dry in the Desert because not only is she a scleral lens expert, but she's super passionate about scleral lenses for dry eye. So we're really excited to have her here. So let's give her a big welcome.
Yeah, so scleral lenses for dry eye, I really think this is going to be the big thing in the next like 10 to 15 years. I feel like people who have dry eye are going to learn more about scleral lenses, and this is going to become a more commonplace practice for managing dry eye. So at least I'm hopeful for that because I can see how much it benefits my patients. So we're going to talk particularly about the Zenlens today. And dry eye, a 2017 data analysis of 75,000 patients who completed a survey found that 6.8% of the adult population, people over 18, presented with dry eye. They said they had symptoms of dry eye. And that likens to about 16.4 million people. Although seeing that number, I feel like that is probably much, much higher. But I also practice in Arizona and you guys are in Las Vegas. So perhaps the arid climate really makes it a higher number. And more, half of people said they had moderate to severe dry eye symptoms, which is kind of interesting because you'd think most people would have a little bit of mild dry eye, but this is really affecting people in a big way. The Tear Film and Ocular Surface Society Dry Eye Workshop did a stage management and treatment of dry eye, and they staged the treatment and management in 4 steps. 1, 2, 3, and 4. 1 is pretty much what you'd expect: artificial tears, lid scrubs, warm compresses. 2 is we're adding some topical and perhaps oral medications, and IPL, LipiFlow. And then 3, they mentioned scleral lenses, and they mentioned it as a bandage lens. And so anybody who's worked with really dry eye patients who have severe dry eye where you need a bandage lens, soft bandage lenses I have not found in practice, either in ophthalmological practice, which I used to be in, or today. I don't feel like they work incredibly well as bandages for dry eye patients long term because number 1, they tend to dry up on the eye anyways. And then number 2, when you have dry eye, if you put everybody under a topographer, you're going to see that they almost always have at least some bit of irregular astigmatism, which is causing them to be blurrier. And so even with a soft contact lens, even if it's correcting their prescription and it's focusing as a bandage, you just tend to get people who have worse vision. And so scleral lenses accomplish 2 things. They accomplish sharper vision and dry eye management. And dry eye, as we know, is classified into 3 classifications: aqueous deficient, evaporative, and mixed. And how do scleral lenses help in each of these cases? It's interesting because I have this guy from the UK who messages me all the time because he has really bad meibomian gland dysfunction. And he's like, oh, nothing's helping me. I have all my glands have dropped out. And he's messaging me constantly. And he's like, should I try scleral lenses? Should I try scleral lenses? I'm like, man, you got to try scleral lenses. You've been messaging me for 3 years. Let's get you, please get into some scleral lenses because they trap moisture in and they protect. So I found that in practice, it's nice to refer to these as fancy Band-Aids. So I tell people, hey, they're going to function as 2 things. They're going to correct all your prescription, which a lot of people don't know because they come in and they say, oh, I'm getting scleral lenses for my dry eye, but can you just make them plain and I'll just wear my glasses over? That's something I get all the time. I'm like, well, first of all, we can't accomplish that, unfortunately. You could, but it would be very difficult because the tear film has its own prescription. But these are going to correct all of your prescription and they're going to function as a bandage. So they're going to protect your eye from the elements, and they're also going to provide a nice liquid Band-Aid that sits on your eye all day. And of course, we know with scleral lenses, it's not the solution that you put into the bowl of the lens that stays there all day. We do have a natural tear exchange over the course of like 3 to 4 hours. It is your natural tears. So dry eye patients might get a little bit of fogging within that time, which we can mitigate with different things. But you use them as these bandages, and they really help people. So other things that scleral lenses do, I think you guys all kind of know this being in practice. They're great for correcting vision in people with corneal transplants, irregular astigmatism, keratoconus, pellucid, post-surgery, which LASIK or PRK. This is kind of an interesting one because I've had a lot of patients come to me over the years who are post-LASIK, and they're usually like a referral from a patient that I already have who has keratoconus or something. And it's like their spouse, and they will have had LASIK a long time ago, and they regressed a little bit. And they're like, oh, I just like don't feel like I see that well. And like none of the contact lenses are really that stable on their eyes, the soft contact lenses. And even when you do custom soft contacts, which supposedly are more stable, there's just still like, they look great in the office, they see 20/20, and in reality, they go out and they just can't see still. They're like, I just feel like I can't see. And it's my belief that people who have had previous refractive surgeries, they've gotten used to a lot of the distortions that these surgeries bring. So they have an oblate cornea essentially, and their brain got used to it, and they were functioning really, really well. And then they regressed a little bit, and then they don't know that they're not seeing as well as they should because their brain is just so used to it. So when you put something like a GP or scleral lens on them, they go, oh my God, like this is so much sharper than I'm seeing, because I don't think that they realize that they could see sharper. So that's a great, if you ever have a patient like that who has like a post LASIK eye and they look like relatively normal, throw a scleral lens on them if they're having difficulty with their soft lenses. That's a really great fix. And then scarring, degenerations, high myopia, high astigmatism. I know we all probably have those patients who have really high amounts of astigmatism where, you know, doctor, if I just put my finger here and just like rotate the lens just a little bit, then I can see well. And you're like, oh, no problem. Like I'll just fudge with the prescription and account for the rotation and it'll be fine. But the rotation is never stable. And so they just keep on doing that with whatever lens you give them, and it gets really difficult. So scleral lenses for those types of patients are incredible. I have a surgeon like that right now. He is in custom soft lenses. And I told him, I was like, listen, I think we've done the best we can do. I think the next step is sclerals, especially if you want to wear them for surgery, which he doesn't at this point in time. But I think that's probably our next step. Other candidates for scleral lenses, the first one I'm really passionate about, exposure keratopathy. I think this is an incredibly underutilized subset for scleral lenses, mostly because I believe that plastic surgeons and oculoplastic surgeons don't know a lot about scleral lenses. They know about them, but they forget to refer out for them. So you still see people say they have an acoustic neuroma removal with a seventh nerve. They cut the cranial nerve 7, or someone has a Bell's palsy, or they have a bad blepharoplasty where the blepharoplasty went great, but they healed in some weird ways. So their eyes don't close, or facelifts can do the same, right? So they have this exposure and nobody thinks about like, hey, maybe putting them in a scleral lens would be really beneficial because you can actually bandage and protect that eye from further damage. I actually had a really interesting patient in New York, and she actually did have a horrible blepharoplasty, and her eyes never closed. So her eye was like this, and it was like huge millimeters. And so her eye ended up scarring over and developing a whole bunch of neovascularization up into her visual axis. So she like couldn't see out of that eye. And I was in ophthalmology and I was at that practice, and they were discussing, oh, we need to do a tarsorrhaphy, we need to do gold lid weights. And I was like, just get this lady into a scleral. If she had been in that from the beginning, she wouldn't have developed this scarring, and it really could have saved her. So that's really something I'm really getting into. I'm going to do like a big outreach with my practice and contacting plastic surgeons just to like let them know that this is an available option. Non-healing epithelial defects, you can heal epithelial defects with scleral lenses. You do have to remove them and put antibiotics in throughout the day, but it is something that you can use that for. Sjogren's syndrome, Stevens-Johnson's, ocular cicatricial pemphigoid, all of these like really severe autoimmune conditions that are affecting the lacrimal gland, they're affecting the mucous membranes, they've scarred over the conjunctiva. These are all things you can use scleral lenses for. And talking today about the Zenlens. So my practice is exactly like Stephanie's. We only do specialty contact lenses. So we don't have an optical, we don't see regular patients. I actually don't even see regular soft lens patients anymore. So any AccuView Oasis -2 is not in my practice unless they were there before. Because we're just so inundated with people who need these lenses. And the Zen, I've used over the years, I've been in practice for 10 years, and I've used every single type of lens available. And I still see people coming into the practice and they're using different types of scleral lenses. And I will say that in the conventional space, so lenses that you put on the eye and you modify them, I do really feel like Zenlens is the best lens, and it really does work the best. There's a couple reasons why, and I'll detail that. But the Zenlens is a type of scleral lens that was developed by Bausch and Lomb. It was developed by Jason Jedlicka, if you've heard that name before. And they're easy enough to fit. They align with the surface really well because we have very specific things that the lenses are able to do that are different than other types of scleral lenses. And one of the things that I found being in practice, like my practice is almost 6 years old now, and one of the things that I think is the most important when you're in practice as a doctor, you have to have a product that works really well, obviously. And there are good products out there. But what I found is the distinguishing factor between Bausch and Lomb and other companies is that I'm ordering like hundreds of lenses, thousands of lenses. I literally got back like on Friday, I ordered like 8, 9 lenses for people. I need the customer service to be good. I need the consultation to know what they're talking about. And when I call in and have a problem, like I need to be talked to right away and to fix things. And I don't want to keep having to follow up. I don't want my staff to have to follow up. So that's really important to me as the customer service. And I do feel like Bausch has the best customer service. And they treat their consultants really well, and just in general, people that work for them. So they tend to stay for a long time. So you don't get a huge amount of turnover, which is also really nice. So the Zenlens features, it includes a 48 lens fitting set. Don't let that intimidate you. I will show you in the other room. I know, Mark. It's crazy. It's crazy. Don't let that intimidate you. It's easy. I'll show you. It's basically like you pick a diameter, you pick prolate or oblate, and then there's a starting lens to go from. And then they have smaller lenses and larger lenses. And I use the smaller lenses a ton, even for dry eye patients. And I'll show one of my patients is in this slide deck, so I'll show you what I did with her. They have prolate and oblate geometry. So prolate means pouching out, oblate means flat, basically in the center, reverse geometry design. We used to have to kind of specify that with labs and be like, oh, I want a reverse geometry design scleral. But with these, it's just an oblate design and it's already in the fitting set. So you use that for post-LASIK, post-RK, new transplants that are very flat, some pellucid, which may be all of the ectasias like right down here, and then you need it to pouch out a little bit more. So oblate designs are flat in the middle, and then they're steeper in the mid periphery. So kind of looks like a mesa. And then prolate is just what you would think with a keratoconic eye. The smart curve technology I'll talk about in a minute. That's like one of the biggest things I think makes Zenlens different from others. And they have markings for insertion. So I just started beta testing a lens for a doctor who's developing it for a company. And good lens, etc. I've been using it. I swear to God, I've mixed these up so many times because I take it out and I put it on the eye, and I think that I like know which one is going in which eye. And I'm like, oh my God, I like forgot which one I put in which eye. And so I'm like comparing the sag values like in the air. I'm like, okay, this one was the higher one and this one was on the left eye. It was crazy because they didn't mark them. And so I didn't know. And so Zenlens has markings, and they have a couple markings. They have, if you order ones for a patient, it has your order number like right on the lens. You'll always know what the patient's wearing. They have the trial lens number on there etched into the plastic. So if you put them on the eye and you're like, oh my God, what did I do? You can just look at them and you'll be like, okay, I'm going to write down like Z10. And that's like the lens that I was using. They have limbal dots that are actually etched into the trial lenses. So if you put on a lens and you think, I think this lens might be too big for the patient, but I'm not really sure, you can look at where the limbal dots are. And if they're way outside of the limbus or like a little bit outside, it's too big for them, you can go smaller. And so that's really cool features that just really help you with the fitting process. and help you to when you're ordering be like, oh my god, what lens would I put on. And the 3-step fitting process, this is where I say don't get intimidated. It's pretty easy. All you need is something to measure the horizontal visible iris diameter. So HVID, white to white, all you need is something to measure that. You could do it with a ruler, and there are special rulers that do it, or just like regular rulers. You can do it with your slit lamp calipers. You can do it with a corneal topographer. I have the Pentacam. I don't know if anyone else has that. They tend to overestimate just a little bit. So there's a picture on the Pentacam that actually has a picture of the person's eye, and there's calipers, so you can actually measure it yourself. You can go from white to white yourself, and I'm assuming that others probably have that too, and that's a really great way to accurately measure HVID. And so you choose like how big is the patient's cornea. If it's 11.7 millimeters, which is kind of that average based on studies, 11.7 or under, you select the smaller lens of the set. If it's 11.8 or above, you select the larger lens. And I'll show you with the actual fitting set. But basically that, you select the diameter, it's really easy. Then you decide, am I gonna use prolate or oblate? And so if you have a keratoconic patient, you're most likely gonna use prolate. If you have an RK patient, you're gonna use oblate. And that's the lens that you're gonna put on. And then all you have to do is there's a lens in the fitting set that's the like recommended lens to start with, and you just put that on. And you can go up if you need to. I would recommend for everybody that is starting Zenlens, just start out with that lens, and then you can go higher or lower when you like get a little more finesse, you get like more tools, all that kind of stuff. But usually the recommended lens fits pretty darn well. And then you look at the lens clearance, the scleral landing. The biggest thing for scleral landing, because sometimes it's really hard to assess edges, is lens on the eye, fluorescein over. Is it seeping in anywhere? If it's seeping in anywhere, that's where you need to tighten up the edge. So that's pretty, and I always grade it as like, how fast is it seeping in? Is it seeping in immediately and the lens is like moving up and down? Tighten it by like 120 microns. It's like you do a big change. If it's just a little bit, do like 60 microns, and they go in 30 micron steps. So 90 is kind of like that, like you're gonna get a good result. 120, I usually don't go much above that because that seems like a big change, and we'll just see. And then perform an over refraction. And if you work in a big practice where you're having like so many patients a day, you're like, I don't know how I'm going to integrate this, it feels like very time consuming. If you have a great set of technicians, you can teach them to do all of these steps because it's just sequential. It's just step by step. What does the patient have? And you can write it out, and it's in the fitting set. Have them put it on. Have them take an OCT if you have anterior segment OCT. Have them take an OCT over all the edges. Have them do the prescription, and then you can just look at the images after and then order the lens. So it can be easy when you have a big staff and it doesn't take up too much of your doctor's specific time. This is the fitting set. This area now is going to be the bi elevation, which I'll talk about in a minute. These are 16s and 17s, prolate and oblate. And then these are smaller lenses, the smaller diameters, which I told you I'm obsessed with. I used to hate mini sclerals. Do you remember when scleral started and everything was mini sclerals, like 13.8 oh my God, it was horrible because you crush the limbus. I just saw a patient like that the other day. He had a 13.5 millimeter lens. It was crushing his cornea, and then the edges were like, wee! And he's like, I'm perfectly happy. I love this lens. And I was like, I absolutely am gonna refit you. I cannot let you go with this lens. This is a horrific lens. And it was like designed from like 2010. And I called the consultant and I was like, can we do anything about this? And she's like, honestly, no, this is like a very old design. And I was like, okay, we're gonna switch it up. So 14.8 and 15.4, those are the smaller diameter lenses. And it's all based on your HVID, right? So smaller HVID, larger HVID, smaller, larger, 16 and 17. So it's pretty easy to pick. These ones would be for people with like smaller apertures, etc. And this smart curve is what makes the Zenlens stand out from the other types of lenses. And this was something, again, developed by the team and Jason Jedlicka. And it basically means when you put a scleral lens on the eye, when you put a Zenlens on the eye, you look at it, you take down your notes, and you give instructions. You say, I want the central clearance to come down by this amount. I want the mid-peripheral clearance to come up by this amount. I want to change the edges this amount. I want the limbus to go up by 50 microns. You give instructions as you see it as a doctor, and you do not have to deal with And this is something that when I was in residency, this is like a very frequent thing that we would have. Okay, I want to order a lens and I want to increase the central clearance by X amount. Okay, Dr. Morrison, what we're going to do is we're going to increase the central clearance by 100 microns. And by doing that, we're going to change the base curve. But by doing the base curve change, it's actually going to affect the mid-peripheral and limbal clearance by X amount. So we actually have to make the lens a bigger diameter, and that's going to affect the overall sagittal value. And so you've gotten into this like realm where you're like, I don't know what the heck I just did, but like I think I ordered it right. And then you get it, and for some reason it's like smushing the cornea, and you're like, what's happening? I don't know why this was different than what I ordered. So this is, you don't have to know that those types of things, especially if you're starting out with scleral lenses. You don't have to be a guru and calculate your own base curves. Like you don't have to do that stuff. All you do is you look at it on the eye and you tell instructions. And the reason that happens is because there's a smart curve design where when one parameter is modified, the others change to maintain the same structure they had before. So what you order is actually going to look like what it looks like on the eye. You dip the central clearance by X amount, the mid-peripheral stays the same and the limbal stays the same. And so everything is the same as what you ordered it, and you can make individual changes without worrying about affecting the entirety of the lens. Which is awesome. We have new technology called bi-elevation. And so bi-elevation is for patients where, and this is super common if you've been in the scleral fitting world for a little bit of time, you put a lens on the eye, no matter what you do, it's sagging, and you have no clearance up here, and you have tons of clearance down here. And you're like, okay, I'm just going to increase the mid-peripheral clearance because it's touching right here up above, right? Touching up here. And then you bump it out and it sags down again. And you're like, oh, well, I'm touching again. How do I get it off of the eye? And this happens because we're finding that most people, their horizontal visible iris diameter is larger than the vertical. And so that's not a spherical eye anymore. That's not a spherical cornea. And so when you put a spherical design on, it just doesn't work the same way that you would think it would. It sags down and you get touching in weird places and you can't seem to make it any better. And I do a lot of freeform designs as well. And you'll notice that the back optic zone is almost always much larger here than it is here. And so you can kind of have validity to the argument that most people are like that. So bi-elevation is a great way to fix those problems without, having to take all those measurements yourself or do anything crazy. And what the bi-elevation does is essentially like, if you have a lens on the eye and you're noticing it's doing two things. Here, if you push it up here and here, it's sagging, right? So you push it up. At the limbal clearance, superiorly and inferiorly, there's a lot of limbal clearance. And then nasal temporally, it's touching. You're like, oh, I'm just going to bump up the limbus again. Boop, nope, does the same thing. And so it's really close here, really far away here, and it's sagging down. So what bi-elevation does is it takes the area from the limbus onwards, just the limbus. So everything else about your lens remains the same. Takes the limbus onwards and it tucks in the edges here. And then here, it just loosens them a little bit. And it's just that little area at the very edge. And so it doesn't affect the central clearance, the mid-peripheral clearance, etc. All it does is it just does like a little finesse of the edges. And so it just like pops the lens back into place and you get better centration. Better centration, you get better vision, and you can get better prescriptions because the optics are more centered too. And so this is a little cute video of basically what it's doing. So optic zone is remaining the same. And then these areas kind of limbal onwards, this would be in the mostly the vertical. And it's just like, boop, like pushing it down just a little tiny bit. Oh, boop. All right, so times to use bi-elevation, like I said, it's touching nasal temporally at the limbus, but it has a lot of clearance here. It's sagging. Or you're having a lot of fogging and you're like, I keep tightening these edges and like I'm still having a lot of fogging. It's just probably not fitting correctly. Or your mid-peripheral is probably too high, but you can check on those couple of things. Have conjunctival prolapse, a lot of things really help. And with Bausch and Lomb, what you get in terms of like on the back end, so you're a business owner and you also have to deal with all of the things that entails, and ordering lenses and making sure that you're being charged correctly, and like all these different types of things. So the consultation team is really incredible. They've been there for years. I've been talking to the same people since I started, basically. And they're available 8 a.m. to 7 p.m. Eastern Standard Time. So we're on the West Coast, so it's nice for us. We don't have to call it like 2 to like try and get someone on the East Coast, like, oh my God, please. And then you have a dedicated in-field specialty market manager, which is just fancy language for like someone is dedicated to just specialty lenses, and that's the person that you're going to be meeting with. So yours is Jason Belfi, and Jason and I do a lot of wet labs here in Vegas where we fly in and we teach doctors how to fit the Zenlens, and it's really fun and it kind of gets you into the swing of things. And you can definitely do that in your practice if you feel like that's something that you want to add. And so if you're interested in Zen and learning more and like maybe getting Jason to meet with you and come out, you can see me afterwards. I have his email and cell phone number, and he said he's happy to give you his cell, so you can just give him a call. And he's really wonderful. And they have handouts and trainings and different things that you can give to patients. And during COVID, they increased their warranty from 90 days to 120 days, and they left it there. So now we have 4 months to make changes. I still tell patients from a logistics standpoint that we have 3 months, because like my patients are always traveling all over the place, and they're like, I'm going to my house here, my house here. And I'm like, okay, well, just like come back because I need to see you. Like we need to finish this. So I still say 3 months, but you know that you have on the back end like a little bit of extra time. And they're also an amazing company to work with because they will always do things for you if you have an extenuating circumstance. Like I have patients who went through chemo treatment and they obviously weren't going to wear their lenses. And so they were able to extend warranties and pause them and different things like that. So that's really, really nice. This is my patient case. So this was one of the worst cases of dry eye that I've ever seen in my life. I feel like I've seen a lot of dry eye. So this 76-year-old female presented to me. She basically had no life. She wasn't going outside. She was inside. The shades were drawn. Her sunglasses were on. She was in excruciating pain, and she was extremely photophobic. She had to quit her job as a substitute teacher because she couldn't teach. She couldn't drive. She couldn't see. And she was living indoors, essentially. Her vision with her glasses was in the right eye 20/70 and the left eye 20/200. And seemingly she had a normal medical history. Her autoimmune testing was all negative, which I think is not correct. I think she has to have an autoimmune disease because you'll see her eyes after this. But she wasn't on any medication. She was very holistic. She liked her like rubs, and she always came in smelling nice. But otherwise, she didn't really take much. This was when I first saw her. You can see that like a very typical severe dry eye patient, her lids were extremely swollen and they were closing. It's trying to protect the eye. This is filamentary keratitis, so there were filaments everywhere. There's SBK all over the eye, filaments that were dragging out. And what I did was I fit her with lenses and then I rushed them. And Bausch was super nice to like get them to me really quickly. But that was like a week span. And in that week, her epithelium decompensated. And so she had to see me within that week. So this was when I first saw her. This was like 3-4 days later. And these are epithelial defects. And I think they're probably just from one of these filaments just pulling off. But I mean, horrible. I had to put her on medications. So you can see this eye, and like being a dry eye specialist over here, she probably has some sort of autoimmune disease, I would say, because I told her, I was like, there's absolutely no way you don't have it. I'm sorry. You can't look like this and have like, this doesn't just come out of nowhere, right? And so over the years, I've tried to get her to get some more testing, but oh well. And the Scleral lens order, her lenses were sagging when I first put them on. So it was having little clearance here, a lot of clearance here. So I did order by elevation. And all I did was I put on a lens with a certain values. And then to add the by elevation, all you say is, I want to add by elevation. And then they do that for you. And so here is where the by elevation comes into place. You have 2 different sag values, but don't let it trip you up. It doesn't mean anything except for like it's going to do that thing in the periphery. So 2 different sag values. We actually had a standard peripheral curvature, which is like pretty you don't really have that often. You usually have some toric landing zones just because most people's scleras are toric. And her VA with the lenses was 20/20. And I was like, thank God. Yes.
How do you decide what refraction to use lens?
Yeah.
There's no way you could refract that point.
Yeah, that's a great question. I was actually going to mention that. So really severe dry eye patients, what I do is I refract them to the best of my ability with the lenses on. I order it, but I always tell them, you're going to have some sort of prescription change because like your cornea is going to look better. And over that time, your prescription will probably be different. And so I always kind of like give that caveat before, but that's a great point. Yeah. It's very hard. I mean, she was the first time I saw her and refracted her with the lenses on, she was probably like 2040, 2030. And we were really happy with that. And then when she came back, it was 2020 when she kind of healed up. So these are her corneas after. It's crazy. I mean, this is so much better. She lives and dies by these lenses. These are like the most important thing. And I had to actually really convince her to get these lenses. Oh, this is my timer. I didn't know it would go off like this. I really had to convince her to get these lenses because she was definitely really on a fixed budget. She was semi-retired. She had to quit her job. And so this was really nice. So if you, after this, we are all going to go into the Sage room, which is over here. And I'm going to do a little demonstration. So nothing fancy. If you want to put on a lens, you obviously can, but I assume like most of you probably wouldn't. But I'm going to show you the fitting set. We also have lots of other products like custom soft lenses for keratoconus. And we have something new with the Zenlens. It's called the Echo. And so it's like that next step above, almost like a freeform lens that you can order without having the freeform like scleral topography. So,
Thank you,
Yay.
Dr. Morrison.